Good evening. Welcome to the Epilepsy Education Webinars presented by the Epilepsy Foundation of Metropolitan New York and its Professional Advisory Board under the leadership of its chair, Dr. Blanca Vazquez, and its vice chair, Dr. Fred Lado. My name is Chilton Harper. I'm the Director of Development. With me this evening is Logan Devlin, who is the Assistant Director of Development and also responsible this evening for all the technical aspects of the webinars. Thank you, Logan. We are very grateful to two wonderful pharmaceutical sponsors who are making this evening's webinars possible: SK Life Science and UCB Pharmaceuticals. For those of you who are with us this evening participating, if you have questions, please put them in the chat box. If we can get to them, we will. If time prohibits, we will certainly answer you after the webinars. I'd like to now introduce the Vice Chair of the Professional Advisory Board, Dr. Fred Lado.
Thank you, Chilton. I'd like to add my welcome to everybody to this first in a series of epilepsy education webinars that are presented by the Professional Advisory Professional Advisory Board of the Epilepsy Foundation of Metropolitan New York. This evening's webinar, as Chilton mentioned, is underwritten by SK Life Science and UCB Pharmaceutical, and I add my thanks to their generous support of epilepsy education. This series of webinars is intended to present current updates and related information on relevant topics in our field. And tonight we're going to have two successive webinars. The first of these will be advances in anti-seizure medications and surgery and neurostimulation. That will be presented by Stephen Wolf and Patty McGoldrick. The second will be on women and epilepsy across the reproductive years. That will be presented by Blanca Vazquez and Lara Marcuse. Each of the webinars is comprised of a 30-minute presentation followed by a 15-minute question and answer. In the event that we don't get to your question, as Chilton mentioned, we will respond to you following the webinar. So we are pleased to present these epilepsy education webinars in observance of Purple Day, which is this Sunday, March 26th. As you might know, Purple Day started some 3 decades ago with a mission to increase general public awareness and reduce the social stigma endured by many individuals with epilepsy, and to empower individuals living with epilepsy to take action in their communities. So without further ado, here's the first webinar: Advances in Anti-Seizure Medications and Surgery, Neurostimulation. Welcome, everybody, and thank you for being with us this evening.
The first webinar this evening deals with new treatments for epilepsy. It is being co-presented by Dr. Stephen Wolf and by nurse practitioner Patricia McGoldrick. Focus on personalized medicine, treatment of rare epilepsies: Lennox-Gastaut syndrome, Dravet syndrome, tuberous sclerosis complex, and CDKL5 atypical Rett syndrome. And here are Stephen and Patty to present the webinar.
Epilepsy. And the thing to remember about this is that people come very late to epilepsy surgery. People are worried about it, and people who have intractable epilepsy, people who have developmental delays and autism, should really not be excluded from perhaps very curative or very palliative surgery. And there's a bunch of different kinds that we're going to talk about. Next slide, please.
So here are a number of the different meds that Pat alluded to that are coming out, and we're going to sort of go through each of them individually. What's important to understand is we're at a very exciting time where there are a lot of new medications out. And these medications are being tried in not only the disorders that Patty and I have already described, but they will even be tested in other of the different types of epilepsies as time goes on. The first one we'll be talking about is Zeltami ganalaxone by Marinus, which was just approved for CDKL5 mutation children. Fintepla, fenfluramine which is indicated for patients with Lennox-Gastaut as well as Dravet's. And then there are two rescue medicines that we'll be mentioning. Both are for seizure clusters. So if you had more repetitive seizures, not for status, but for clusters of seizures, one is Valtoco, which is diazepam, and one is Nasalone, which is midazolam. Next slide, please. Patty?
So in addition, and let me just say a word about the rescue medicines. If you could go back a slide. When we changed at the beginning of the pandemic to really doing a lot of telemedicine, it was really incumbent upon us as providers to make sure that everybody has a seizure action plan and rescue medication. We were really worried about people going to the emergency room, obviously, during the height of COVID. So as consumers, as family members, please make sure that your family member has a rescue drug prescribed for them. Valtoco is diazepam, that's approved for children 6 and above. They're both nasal sprays, and then Nasalam is midazolam, approved for patients 12 and above. You should have this at home. It should not be expired. They should have it in school and at work, and all the family members should know how to use it so that there's no delay in getting rescue meds. Okay, now
Great
back
point.
to, yeah, really important. All right, so now back to the next slide. So diacomet is stiripentol, which has been around for a while. We had been importing it. It is used for treatment of seizures in children with Dravet syndrome or people with Dravet syndrome, ages 2 and older. They have to be taking clobazam at the same time. Then there's Epidiolex, which was FDA approved in June of 2018. This is the pure CBD. We had lots of stuff going on about medical marijuana before that. This is a tested FDA approved pure CBD without THC in it. It is approved for children 2 and older and adults. I don't mean to just be children, but people with Lennox-Gastaut syndrome or Dravet syndrome or TSC complex. And then we have Xcopri, which was approved in November of 2019. So this is cenobamate, approved as an anti-epileptic drug for the treatment of partial onset seizures in adult patients. So I think that people tend to go back to the old meds that have been around for a long time, the valproic acid, the topiramate, lamotrigine, zonisamide. Those are all great drugs, but I want people to be aware that there are newer ones that should be tried, and sometimes people are unaware of their availability. Next slide, please. Steve.
So let's talk about Zeltami, which is the treatment for seizures associated with CDKL5, otherwise known as CDD. So the new terminology, and these are for kids 2 and older. Again, right now, it is just indicated for these type of genetic seizures, but I think in the future, we're going to see this being tested on a bunch of other seizure types. What's interesting about this medication, it does come in a liquid. It's given 3 times a day. It must be given with food. That's the best way. You don't have to refrigerate it. And really, it's very well tolerated. The most common side effect that we're seeing with this medication is sleepiness, a little bit of drooling, some allergies, but really mostly pretty well tolerated. Sedation just seems to be the biggest issue. Make sure you speak to your medical provider about what other medications you're on. It does work in a unique mechanism of action where it works on GABA receptors, both intracellular and extracellular. What that means, it has a broader spectrum. GABA is an inhibitory receptor, and that's important to sort of, as you're working with your family member, to learn what medicines they're on and what the mechanism of action is, because you want to have, if you have a family member that has poorly controlled seizures, you want to use different mechanisms of action. And a lot of the medications that Patty and I are going to be talking about are new mechanisms of action, or a different type of mechanism of action than some of the older medications that have been around. So it's a very interesting medication right now just for a singular genetic disorder, but in the future, who knows what it's going to do. Next slide, please.
Go ahead, Steve.
Okay, so Fintepla is another unique mechanism of action medication. It's indicated for seizures with both for Dravet syndrome and Lennox-Gastaut. Patty already mentioned to you what those seizure types are like. And this is for the ages of 2 and older. And we've collected a lot of data. I was lucky among many of us to be part of the studies of doing this for children. And we watched how many drop seizures they had. And we saw a significant reduction in these children with their drop seizures or their big shaking seizures. And what was interesting is this drug works on serotonin. Now, a lot of you have heard about serotonin in reference to depression and anxiety, but this is the first serotonin-based drug that works on serotonin receptors that was used for epilepsy. It's really sort of fascinating. Now, you might have fenfluramine before, and that was because it used to be a drug used for weight loss, but at a very, very high dose. And you might have heard some things about side effects that the patients who were using it for weight loss were experiencing, and they were experiencing a risk of valvular heart disease and pulmonary arterial hypertension. So because of that, Fintepla for epilepsy is a much, much, much smaller dose. And during studies, we've monitored over 3,000 patients in the world on the medication with over almost 4 years worth of data showing very safe efficacy and not seeing these kind of valvular heart disease issues and pulmonary heart disease issues. But the trick about this medication is we want to be safe and monitor the patients. So we want them to get a baseline echocardiogram and then every 6 months a follow-up echocardiogram while they're on it. So even though we're not seeing anything going on as of yet, we want to make sure as the years go on that we're monitoring these patients carefully. And so far, everything has looked really good. So this is a very unique medication with a unique mechanism of action. Anything else to add, Patty, there?
Nope, good work. Next slide, please. All right, Valtoco, I briefly talked about. So it's an intranasal diazepam. It is a rescue med for clusters of seizures. There's a weight and age-based dosing when the child turns 11, so 5th grade-ish, 6th grade. You need to go back and rethink the dosing. The median time to stopping a seizure after it's given nasally is about 2 minutes, which is very quick. And most of the people are back to themselves in 1 hour, which allows people with seizures to return to what they were doing. Very few adverse effects. Most common are bad taste in the mouth, nasal irritation and drowsiness. And it's FDA approved again for children 6 and older. There are studies going on looking to get FDA approval for children 2 to 4 years old. It's not ever going to be approved in babies because there is an adverse event associated with one of the ingredients, not the diazepam. Next slide, please. Nasalam is another nasal spray for the short-term treatment of seizure clusters. So the seizure clusters are defined as clusters of seizures over and above the normal frequency of seizures. So if you normally have 2 seizures a day, if you have 3 or 4, then that would be a chance to use the rescue medicine. It's again a nasal spray. Nasalam is dosed at 5 milligrams and can be repeated with another 5 milligrams in the other nostril. Next slide, please.
So dicominate is another medication that recently came from Europe to the United States. It was very heavily used for patients with Dravet syndrome, as well as other seizure types in European Union. Here it is approved for Dravet syndrome in children and best in use with patients who are on already clobazam for 6 months and older. And it is another interesting medication that works on GABA. So you're hearing about GABA again. And it helps to increase GABA and GABA release within the neurons. And GABA, again, is inhibitory to help control seizures. But it, too, like all the medications, can have side effects with sleepiness, decreased appetite, agitation, and coordination issues, and decreased weight. That's sort of the bigger issue, is the decreased weight, nausea and tremor, as well as slurred speech. And robots, this is a really exciting time of new things that have been accomplished safely with patients with open resection surgery. All right, so I think we are up to our questions. We ran a little bit over, and we don't want to take away from the next amazing talk. If anybody has any questions, please type them in, and we will try to address them. And if we can't get through them all this time, as you type them in, we'll make sure we get back to you with those results, those answers. But I think we stunned them.
Dr. Vazquez and Dr. Marcuse are ready to take over.
Well, since it's nice and quiet, let's pass over to the women's issues and learn some more.
Thank you, Patty and Stephen, and I need to see that. And sorry about that, as my economics professor used to say, that compelling graphic. When we have the final version of this put online as an educational tool, needless to say, it'll all be appropriate, and that was wonderful. SK Life Science was the sponsor of that particular webinar. They're a subsidiary of SK Biopharmaceuticals. They're focused on developing innovative next-generation drugs. SK Life Science has 28 years of experience in research and development and is dedicated to changing the status quo in the central nervous system. SK Life Science currently has 8 compounds in the clinical development pipeline. The directors, the professional staff of this pharmaceutical company are absolutely superb, and they have been wonderful partners for the Epilepsy Foundation of Metropolitan New York. We thank them very, very much for their gracious support of this first webinar. I'd like to bring Fred back in, and he's going to now take us up to the second webinar this evening. Fred?
There are 2 questions there.
So why don't we take the questions? Yeah.
All right, first one from Katie is, what effort can we make to connect potential patients to other patients who've already received similar procedures? That's a great question. If you speak to your medical team, they usually will have other families that have done that, and many centers have ambassadors. And so, usually the other families like to talk to other families. So I think that would be my recommendation, is to speak to your medical provider. The next question was, is it considered failed medicine if you have seizures while on the medication? Great question. The answer is not necessarily totally failed. You have to speak to your medical provider and find out where your dose is. Are you on the maximum amount of dosing of that medication? Have they tried it in the right combination? And then that will help you decide if you failed that medication. If you're just starting the medication, you have a seizure, that might not necessarily be a failure, but if you're on a good high dose, then that might be at that point considered a failure. Next question is, have we ever placed a RNS neurostimulator in patients under 18? Yes, we have. A number of centers in New York City have a number of patients under 18 years old, even though it's not FDA approved. And this is currently being done in a FDA approved trial for children 12 and above who have focal seizures. So yes, there is a lot of patients in the United States who are hooked up under 18. Another question is, where can you get more information about Xcopri? And there is information online, as well as speaking to your medical provider, who can get the medical science people from the company to give you very specific information about the drug-to-drug interaction. The biggest drug-to-drug interaction is sedation with these medications. So it's important to have a plan if you start becoming tired when you're starting a new medication, how to decrease those side effects. I think that answers all the questions, Fred, and back to you.
All right. Well, thank you, Patty and Steve. That was a terrific review of treatment advances for epilepsy. Now it's my pleasure to welcome Blanca and Lara for our second webinar, Women in Epilepsy Across the Reproductive Years. Thank you, Blanca and Lara, for making this presentation this evening.
Lara, you're on mute. Oh, let me start again. Can you hear me now?
Yes, I can. Yes.
Thank you very much for having me. I was just saying that Steve and Patty, that was a wonderful talk, and I learned some things myself. And it is such an honor to be giving this talk with Blanca, who is my colleague and my mentor, and I've known her for many, many years, and it's nice to share this forum with her. And it's actually so wonderful to give this during Women's History Month, which is the month of March. So it feels very apropos. So we can get going with the next slide. So one of the concepts is that it's really important for epilepsy doctors to provide women and girls with the maximal amount of information so that they can make informed choices for themselves. But at the same time, we as doctors have to anticipate issues before they arise and discuss them with each individual patient. So we're going to talk a little bit about epilepsy in women of childbearing age, pregnancy and epilepsy, cognitive outcomes of children born to women with epilepsy, and breastfeeding. And then Blanca's going to take it away and talk about a couple more things. Next slide. So let's say that there's a young woman with focal epilepsy and she's having a lot of seizures on levetiracetam. And I don't mean to throw any shade at levetiracetam. This is just an example. And her neurologist changes her to carbamazepine, which is like, an okay choice. And then at her next visit, she's so happy because her seizures are under control. But then she says that she's like gained some weight and she's kind of nauseous and she's not had her period in a few months. So like what all happened here? So she's pregnant. And did the Tegretol get her pregnant? Not exactly, but kind of. Next slide. So one of the things that we think about as healthcare providers is the interaction of medicines, and especially some of the older medicines are going to interact with oral birth control pills and make it less effective. And carbamazepine is one that really interacts and really makes oral contraception less effective. So that's an issue that when we make this change in somebody that is of childbearing age, we have to think about that and foresee it and talk about it as healthcare providers. There's a lot of medicines that don't interact, so there's plenty to choose from. And then there's a little bit of something to think about on the other side, which is that sometimes oral contraception can make the epilepsy medicine less effective. So sometimes you might want to repeat the drug levels to see that the drug levels are okay if you're a woman and you've just started oral contraception. Next slide. Okay, so this is the next story. This is a 24-year-old woman. She's 14 weeks pregnant, and she was watching TV. And then she felt a very, very intense and sudden feeling of fear. And she felt a vibration in her knees, and then she had a witnessed tonic-clonic seizure. She has a history of epilepsy with the exact same aura, but she's been off anti-seizure medicines, and she's not had a seizure in 3 years. Should her doctor restart medicine? And if yes, then what's the safest medicine, and what are the issues to consider? Next slide. So I like to show this photo because I think sometimes in life, and definitely sometimes for women with epilepsy, it feels like you're on a very narrow little rope making a decision where on one side there's the risk of seizure and the other side that there's the risk of medicine. And I think most epilepsy doctors would really start a medicine at this point because she is at risk of having another seizure, and big seizures can be dangerous for her. And if something is dangerous for her, then it can be dangerous for the child that she's carrying, for the baby that she's carrying. So next slide. So luckily, it's not like it was. It's not like 20 years ago when we didn't have really good data. We have all of these international registries, one in North America, one in Europe, one in the UK, one in Australia, that registers women when they find out that they're pregnant and follows them through pregnancy, and then checks up on how the babies are doing to see if the babies have had any malformations. Next slide. Now, this is actually a really hard slide to read, and I'm sorry that it kind of came out so small. I personally can't even read it, and I put it together. But this is just showing the rates of malformations and it's showing two different registries. And the malformation risk. There's basically one medicine that's always the worst in every registry, and that's valproic acid, otherwise known as Depakote. That is definitely the worst, with the highest rate of malformation. That rate is about 9 to 10% if someone's just taking valproic acid, and it can go up if somebody's taking a whole bunch of medicines together. Medicines that are considered really pretty safe in pregnancy are lamotrigine and levetiracetam. And newer medicines, we don't have a lot of data on, but we can find out the data that's out there if we need to. If a woman with epilepsy gets pregnant on one of the newer medicines, we can try to find out more information. We like women that want to have babies to be on medications that we know a lot about, like lamotrigine or levetiracetam or oxcarbazepine, that all look pretty safe in pregnancy. The main thing I want to say is we are here to support you. If one of the things you want in your life is to have a baby and to have a baby that's healthy, we can really, really help you with that. And the more a person comes and talks about that with us, and the earlier they start to talk about that with us, the more helpful we can be. And your goals in life are our goals. And having babies, if that's something that you're interested in, that is a real quality of life issue. And we are 100% here to support you. Next slide. This is another tiny chart, which basically goes through some of the different malformations on the different medicines. So the malformations can occur in the cardiac system or cleft palate or in the kidneys. And the malformation rate is quite low for things like lamotrigine. It's like a 2% chance of a malformation. So it's quite low. Next slide. The next question that is important to ask is, what about if somebody has a seizure while they're pregnant? Is that going to hurt the baby? It's true that many women with epilepsy in pregnancy will have seizures. That does sometimes happen, particularly people that don't have epilepsy that's well controlled before pregnancy. And in general, they do totally fine. The bigger the seizure, the more we kind of worry. A big generalized tonic-clonic seizure during pregnancy can produce fetal low heart rates and deceleration and what's called decreased variability. It has been described that there's been some major problems with big seizures. Uncontrolled seizures are dangerous for both the fetus and the mother. And then smaller seizures, we really don't know, and they don't seem as dangerous. And I know this slide feels like kind of scary, and why would I put it up? And the reason why is that women who want to get pregnant often say something like this: I don't want to take medicine during pregnancy. I don't want to take that risk. I'm just going to stop my medicine while I'm pregnant. I don't mind if I have seizures. That's about me. It's not about the baby. I'll take that risk for the baby. But having seizures is not healthy for you, and it's not healthy for a developing fetus. So that's why we tend to recommend, we really do recommend ongoing anti-seizure medicine throughout pregnancy. And we really feel like it can be done safely. Next slide. The other thing that you really need a crackerjack epilepsy doctor on your side is that these medicines can bounce around in pregnancies and often you really need a lot more medicine, particularly with levetiracetam and lamotrigine, particularly with lamotrigine. You really might need to take more lamotrigine throughout pregnancy. So you really need to be partnered with your epilepsy doctor, and your epilepsy doctor has to be partnered with your OBGYN. It has to be like the little triad where we're all really working to understand what's going on. I will often have the OBGYN draw the level of the anti-seizure medicine so that, someone who's pregnant doesn't have to constantly go to the lab and their OBGYN and the neurologist. We try to consolidate that. Next slide. The biggest marker of seizure frequency in pregnancy is what's been going on in the last 6 months of your life. If your seizures have been controlled before you get pregnant, they're going to be controlled most likely during your pregnancy. Some people's seizures even get quite a bit better during pregnancy. So if you're interested in having a baby, one of the things that can be worked on is really helping you with seizure control before you get pregnant. Okay, so let's say a woman delivers a healthy baby and she's on levetiracetam. And then she wants to know if the fact that she took a medicine during pregnancy will affect her baby's development and cognition. And this has really been looked at. We can go to the next slide. And this is a study called the NEED study and the MONEED study that looked at the IQ of the baby at 6 years old and compared it with what anti-seizure medicine that the mom was taking. Next slide. Okay, so hang on with me a little bit with this. So there's two things that I want to talk about that's being shown in this slide. One is the IQ of the baby, and everything to the left is lower and to the right is a higher IQ. And the dotted line is the women that didn't take folic acid. And the solid line is the women that did take folic acid. So the first take-home point is no matter what medicine you're on, if you take folic acid, your baby is likely to have a higher IQ. And there's wonderful data for this for women without epilepsy. That's why there's folic acid in our cereal and stuff, because it's known to be so good for helping prevent malformations and also for the cognition of the developing baby. And then the other thing you'll notice here is that the very, very worst medicine for IQ is also the worst medicine for malformations, and that is valproic acid. Other anti-seizure medicines, the babies do much better, lamotrigine, carbamazepine. Okay, next slide. And this is looking at the higher the dose of medicine, the higher the effect, the worse the effect on cognition for some medicines. And this is a kind of complicated slide, but if the more valproic acid you take, the much lower the baby's IQ will be. Whereas lamotrigine, if you look onto the top right-hand little graph, lamotrigine, the more lamotrigine the mamas took, it didn't actually have a bad effect on IQ. So basically, valproic acid in kind of every sense is the most dangerous medicine in pregnancy and the worst medicine for cognition. And it is very dose dependent. The more valproic acid you're taking, the worse it is both for malformation and for the cognition of the baby. But I will say that a woman came to me this year and she was on valproic acid and she was already like 13 weeks pregnant and she had horrible epilepsy. And I was just meeting her and we couldn't change it. And she went on to have a totally healthy, wonderful baby who's developing just fine. So there is always hope. Next slide. Okay, the next is a woman who's who just had a baby and she's on lamotrigine and she really, really wants to breastfeed her baby. And should she? And this was a study that looked at the levels of anti-seizure medicine in the blood of babies. And if you can just advance it for the little pop-up so I can read it. And the amount of anti-seizure medicine exposure via breast milk is likely substantially lower than the fetal exposure during pregnancy and appears unlikely to confer any additional risks beyond those that might be associated with exposure in pregnancy, especially given prior studies showing no adverse neurodevelopmental effects of breastfeeding while taking anti-seizure medicine. So the answer is yes. If a woman wants to breastfeed, we should really, really encourage her to breastfeed. And the levels in the baby's serum is low. Next slide. This was just another study about that point, that there was no adverse events of exposure to breast milk observed at age 6 years, and breastfed children tended to have higher IQ and verbal abilities. So, you know, I'm really about supporting women in what they want. So if a woman wants to breastfeed, I really, really support that. But if a woman doesn't want to breastfeed, I'm behind whatever the woman wants. Next slide. So in closing, family planning is really a quality of life issue. Pre-pregnancy serum levels are important. If one medicine can work for the seizures, that's important. That's better than polytherapy. And there's no single right choice for all women. And we want to individualize plans for everything depending on the individual woman. And if you think something is kind of embarrassing to talk about with your neurologist, or you're not sure if you should talk about it, whether it's getting pregnant or breastfeeding or libido or whatever, it is probably important to just bring it up. We're here for you. And if you're pregnant, register with the North American Registry.
Fantastic, Laura. Thank you so much for that wonderful review. I think you've touched on so many aspects of caring for women and epilepsy across the reproductive years. So let me just go on next to sort of a review. We touch on 1, 2, 3, and 4, and then my next talk is going to be about what happens after menopause. It's really not just to get through pregnancy. It's about life across the reproductive years. And I'll talk a little bit about mood and bone health as well, including weight and some of the anti-seizure medicines. Next. So there are many comorbidities. That means that when the patient has epilepsy, they can also have other medical problems. And we have to look at that as one U. And that really is important, because it's not just about how many seizures, what side effects, but comorbidities can actually take a toll, perhaps even more so than infrequent seizures. So let's talk about someone that has memory problems, cognitive complaints. So we have to address that, because that happens every day. It's with you when you work, it's with you when you're trying to do homework with your children. And that's something that we need to sort of talk about it. Is it the seizure? Is it the medicine? Is it the underlying cause of the epilepsy that is causing trouble? So I think it's really important that women with epilepsy bring on to conversation other aspects of your care that is not just getting pregnant and getting through the reproductive cycles. Another area which I think we should pause and talk about, not just for women in epilepsy, but today we're concentrating in the aspects of care that are relevant for women, and that is mood. So we do know that patients with epilepsy have a comorbidity existing. It's very high of patients that have anxiety, depression, and any earlier than stress. Talk about, because some of the anti-seizure medicines can also impact the ability drug. The neurologists are going to look at all that, not only which medicines can make you focus better, but which ones are going to help you with your mood and prevent other mood changes for women in epilepsy. So we'll talk a little bit about osteoporosis and weight changes in the next slide. So what happens? Is that so a third of the ladies are going, and the other third may have decreased the frequency of seizures. And why is that? It's because we think that estrogen is the facilitator for seizures, and progesterone is probably the calming one. But during that menopause period, both go down. This is very important that we take that in, because we want to make sure that we don't say, okay, when I go through menopause, I will go down in my seizure frequency. Next. Let me read. Lara, can you hear me?
Sometimes I'm having a little trouble hearing you. Is it, I think it's your signal.
Maybe. All right, let me try. Let me continue. Okay. So some of the anti-seizure medicines can affect weight, and we don't really know the mechanisms, but it's very often that we associate some of the medicines with either losing weight or gaining weight. Can we go to the next slide, please? So some of the medications that we associate to see weight gains are valproic acid, gabapentin, carbamazepine, thiagabine that we don't use anymore. The weight neutral are lamotrigine, levetiracetam, brivaracetam, phenytoin, lacosamide, perampanel. And we are seeing some drugs that are more associated with weight loss. Topiramate, we see zonisamide, the cenobamate, felbamate are drugs that were associating with decrease in weight. Next. So another aspect of caring for a woman is bone health. Some anti-seizure medicines are associated with osteopenia or osteoporosis. And some of the anti-seizure medicines that are strong inducers of the liver may increase the bone turnover, and that will put the patient at risk of having osteoporosis and osteopenia in multiple areas of your skeleton at a very early age. Next. So the definition is based on scores that deviate from the normal for a patient at that age, and the standard deviations will tell us, is it osteoporosis, which is really weak bones, or is it osteopenia, which is the beginning of the minerals in your bones getting weaker? And with that, we decide what kind of treatment we are going to implement for that particular patient, because it needs to be treated, it needs to be discussed with the bone doctor. Sometimes it's the rheumatologist, sometimes the GYN. So we have a group, a team of doctors that will work with us if the anti-seizure medicine are affecting the bones. But my number one priority is to prevent that. So to choose the medicine that does not impact your bone health is key. But if we find that someone is having bone osteopenia, then we really have to change for a medicine that is not going to accelerate the process in a young woman. Next. So there are several ways that we can measure the metabolism associated with bone loss. And these are some of those tests that we can run. But the number one guide is to use the bone density. It's a test that we need to follow to protect patients, to prevent anyone to get accelerated bone loss and then have fractures when these could be avoided. Again, choosing the drugs that are not going to put your risk of having bone loss is probably the right thing to do to prevent this problem. Next. So in conclusion, I think Laura went through a very detailed way to looking at reproductive health. So it's not only getting pregnant, it's not only prevention of pregnancy, but we want to do that. It's also looking at bone health, monitor mood changes. It's very important. If this is not part of your discussion with your doctor, you need to bring this up if there are issues. I personally feel that most doctors treating epilepsy these days are very aware of the effect of not just the epilepsy, but the anti-seizure medicines that can have in your mood. If there are issues of sexual dysfunction, weight gain, bone health, consider switching to another agent. I think that today we were really enchanted by the presentation early on of how many drugs we have now in clinical trials, how many new drugs we've had in the past several years approved for the treatment of epilepsy, that we have many choices that can sort of present a new option for patients having any of these issues. Always try to register if you know anyone that is pregnant and has epilepsy. The registry is the only way that we're going to get to the next step, to collect meaningful numbers, to be able to continue to do these talks and to educate the doctors and the patients of how to manage women across the reproductive years, but specifically the registry for pregnancy. Next. We need to be mindful and keep our eye on the ball. And that is not just about pregnancy. This is relevant for any woman of childbearing age across the reproductive years, during menopause, and of course, it's adding life to your years, it's adding good quality of life, and the neurologist should be very mindful that the choices of medicines can definitely impact quality of life for women with epilepsy. Next. I always use this as my closing slide because I like to say no seizures is really a big goal, but good quality of life and preventing problems for women with epilepsy, it's really important. Next. I think we're getting there, and that is, yeah, we're ready for some questions.
I put in the chat the number for the North American Pregnancy Registry, and Patty McGoldrick put in the name, so now you have everything.
Perfect.
And really important to register. We really need more information about women who are pregnant with epilepsy, as Lara said. And Lara, you have to register yourself, right? Your provider can't do it for you.
Yes, you have to register yourself. It's super easy though. They try to make it easy. And that's how we get the, I just had somebody that is on, what is she on? She's on Briviact. So I had to go and find out all the numbers that we could from the registry, even though they're very small, to get some information, because you can't study pregnant women in that way and give a lot of pregnant women a medication and see what happens. The only way we get this information is through these registries. Okay, I'm going to give this question to you, Blanca. Is there something you'd suggest taking to help with bone health?
So I think that it depends how much deviation from the standard. But to prevent bone problems, the key is not to use drugs that are going to accelerate the bone turnover. It's really the only way. We have looked at the amount of calcium, vitamin D that you will have to take when you're using the enzymes inducer, and it's so much you will have to, it's really impressive. So really using the drugs that are not going to put you at risk of osteoporosis is really the key to prevent it.
And one of the reasons we want to prevent it is that epilepsy and osteoporosis is a bad combination because people with epilepsy sometimes fall, and we just really want to prevent it. Somebody asked, Dr. Vazquez, can you speak to any issues that may arise from menopause?
Yes, I think that one of the issues is that your metabolism changes, and the amount of medicine that you require may change as well. So following levels is very important, especially, I'm going to give you an example. If you're taking lamotrigine and your doctor decides to give you hormonal replacement therapy, then that is going to increase the metabolism of lamotrigine, and your level is going to go down, putting you at risk of having breakthrough seizures. So during that transition menopause, we have to coordinate very much with the GYN team to avoid using medicines that are going to put you at risk. So I have another question here. Should women with epilepsy have bone density tests at a particular age? So we do know that patients that are taking enzyme inducers, drugs that are associated with bone loss, are more need to be followed. The recommendation is every 3 years. In the old days, it was to do a DEXA scan every 5th year on it. But I personally find that collaborating with the bone density team and with the bone team will help me guide how much I need to pursue this without going for treatment. I also think that there is no reason to do bone density studies in a woman that is not using any enzyme-inducing drugs or drugs that are associated with bone loss.
And just to note that men need DEXAs too. This is an issue that, you know, you can have a big, strong guy has a lot of muscles and is not somebody that would normally get osteoporosis. Like, I'm a great person to get osteoporosis, my demographic, but even somebody that's not a demographic to get osteoporosis, if they're on an enzyme inducing agent or valproic acid, we would do DEXAs on men as well.
Perfect. I just want to tell you that I was talking to two professionals yesterday in the field of epilepsy, and someone said, oh my gosh, this is the first time I hear about bone loss and anti-seizure medicine. So that's what I think the value of these conversations and conferences, that sometimes we don't have enough time during our visits to talk about all these issues. But if you bring notes, Dr. Vazquez, I want to talk about bone health, I might, you know, it facilitates that conversation in the office with your doctor.
Somebody's asking for a list of the meds that can increase the risk of bone loss. I'll put some in the chat.
Okay, so I'll tell you that the mechanism by which these medicines can be associated with bone loss, it's different for some drugs, but we do see that the strong inducers of the liver metabolism are like phenytoin, carbamazepine, as well as phenobarbital are associated, and some data for valproic acid as well, which is a different type of mechanism. Thank you, Lara. That's good.
You're welcome. Anytime. There's probably some that we're missing there, but those are the real culprits. And sometimes I meet somebody that hasn't been on carbamazepine for a decade, but was on it for 15 years, and I'll do a DEXA on that person too, because they are more at risk of having osteoporosis or osteopenia.
Okay, thank you very much, Dr. Vazquez, Dr. Marcuse. That was wonderful presentation, and we want to just take a minute to thank our dear partners, UCB Pharmaceuticals, who sponsored this webinar. Inspired by patients, driven by science. We've had a lovely relationship with them for years. They are just a very caring company, and they have wonderful directors and professional staff, and we want to thank them also. That's the end of the epilepsy education webinars this evening. Thank you very much to everyone who participated. Thank you to SK Life Science, to UCB Pharmaceuticals. Particularly thank you to our professional advisory board, to Dr. Vazquez, to Dr. Marcuse, to Patricia McGoldrick, nurse practitioner, to Dr. Wolf, to Dr. Lado. Thank you all for being here. And Blanca said it perfectly. It's only by communication and by relevant information that we really can make a difference. And I think this is a very, very important thing for us. And we will be tidying up this particular recording and getting it put out online next week, so it'll be available. I think it's a very valuable educational tool. As Blanca reminds me, it's a virtual library. And lastly, I really want to thank two people who are indispensable to what's happened this evening. I certainly can't be here without them, and that, of course, is our executive director, Eleanor Latouche, and the head of our board, Roger Cooper, Dr. Roger Cooper, who completely support this initiative and will continue to support more of these in the future. A very important person said, to manage an organization is to manage the future. To manage the future is to manage information. And I think that's a pretty good way to end this evening. And I want to thank all of you for being with us. The Professional Advisory Board, you're magnificent, caring people. We wish all of you a very good evening, and thank you very much.
Bye.
And thank you, Chilton.
Thank you all. Thank you, Chilton, for setting it up. Thank you for all the people who sponsored it. And thank you, patients, for letting us take care of you.